Okay, so I did not get through lecture. Obviously, I've still got quite a bit to do. So I'm going to try to do bowel elimination here and pediatric elimination so that you'll have them for your test on Monday, I believe it is. All right, bowel elimination. So digestion starts with the mouth, esophagus, stomach, small intestine, large intestine, also known as the colon, the rectum, and the anus. Kind of start with the basics. All right, bowel elimination or defecation is the act of expelling the feces or stool. All structures of the GI tract, especially the large intestines, must function in a coordinated manner. The large intestine is where water is removed from remnants of digestion and causes a consolidated mass. Peristalsis, we talked about this earlier, is the rhythmic contractions of the intestinal smooth muscles. Helps move things down, so it moves the fiber, water, nutritional waste through the ascending, transverse, descending, and sigmoid colon onto the rectum. And you have increased peristalsis with eating. It's called the gastrocolic reflex. This is normal. Sometimes cramping occurs as a result of the gastrocolic reflex, as gastrocolic reflex occurs. And people often will have the urge to defecate. All right, the process of defecation, you have to have peristalsis, you have to have the gastrocolic reflex, which propels the stool forward, packing it into the rectum, the urge to defecate as the rectum distends, the anal sphincter, which is a ring-shaped band of muscles, and the Valsalva maneuver, which is the contraction of the pelvic floor and abdominal muscles to increase intra-abdominal pressure, forcing out the stool. All right, so here's just your picture of your GI system. All right, assessment and elimination patterns. So elimination patterns, you need to be sure that you determine the client's usual patterns. What is their usual frequency? What is the usual effort required to have a bowel movement? Do they require elimination aids usually? So just because we assume everybody has one bowel movement a day, that's not necessarily the case. It may be normal for someone to have a bowel movement every other day. It may be normal for someone to have 2 or 3 bowel movements a day. So you need to be sure to determine what is normal for the client, not what you think is normal. Right? As the nurse, I hope you'll remember when we did the GI assessment, which thing are we doing first? Which nursing process are we doing? So hopefully remember that we're inspecting and then auscultating. Okay, with health education, we're going to identify, have the patient identify their own bowel patterns. Ask them about daily exercise because that helps the stool to move through the system. High fiber diet. Do they eat a high fiber diet? Things like pears, apples with the skin, nuts, beans, bran, oatmeal, whole wheat, lentils, rice, raw carrots. All those things are very high in fiber and will help prevent constipation. And we need to encourage that they have 8 to 10 glasses of water a day. Right, characteristics. Stool characteristics. Abnormal things would be that if the color was black, yellow, or green of the stool. Sometimes it's an odd thing, but sometimes color is related to diet. For example, kids in particular, just because that's what I think of, those are the phone calls I get all the time, are eating blue Jell-O, pudding, yogurt, things like that. It can cause the stool to be blue. Black stools are often an issue with an upper GI bleed in the esophagus, stomach, or the first part of the small intestine. And maroon or bright red blood would be a lower GI bleed in the large bowel, rectum, or anus. Now, that is not to say that every time you look at a stool, if it looks black, there's definitely a bleed. That's just kind of a guideline, okay? If there's a real strong foul odor, the consistency is watery, hard, or dry. And again, these things have to be defined when you're discussing this with a patient. I think I've talked about this on Monday. If they call and they say, we got diarrhea, well, what exactly is diarrhea? Because diarrhea to some people is having 1 or 2 loose stools, and that's not true diarrhea, okay? The shape, is it pencil shape? Is it like little pellets? Are there any unusual components to the stool? Worms could be in the stool. That would be if the patient had pinworms, possibly. Blood or mucus. Patients with Crohn's disease or ulcerative colitis or some cancers will have mucousy stools. All right, alterations. Let me move this. Alterations in bowel elimination. So constipation. We have 4 types of constipation: primary, secondary, iatrogenic, and pseudoconstipation. We're going to talk about these. So primary, nurses can treat primary constipation. What causes it? Secondary constipation. Iatrogenic, what is it? What causes it? Pseudoconstipation. Okay, we're going to talk about all these. Fecal impaction, flatulence, diarrhea, fecal incontinence. All right, constipation. Dry, hard stool that's difficult to pass. Can a client still have a bowel movement if they're constipated? So that's a good question. Yes, they can still have a bowel movement while they're constipated. What may happen is they may get impacted stool in the bowel, and they may have looser stool developing, and it can seep around the impaction and then still form again, and they can still have a normal bowel movement. Signs and symptoms of constipation, though. The patient complains of abdominal fullness and distension. They have pain when they have a bowel movement, pain with defecation, that's having a bowel movement. Decreased frequency of bowel movements. Change in the stool, more loose or more hard. So just because it's loose doesn't necessarily mean it's diarrhea. It could be that they've had an impaction and this loose stool is seeping around the hard impaction. Okay, so love my picture here for constipation. All right, so we've got primary constipation. The nurse can treat. Causes of primary constipation will be things like inactivity. When we're inactive, our gut is not moving and we can become constipated. We can easily fix that by encouraging ambulation, and even if it's passive range of motion, rocking, walking, anything we can do to help. Inadequate dietary fiber, insufficient fluids, and ignoring the urge to defecate. Now, this is a big thing with kids. They often ignore the urge to defecate, especially when they're potty training. They hold it in, then they get constipated. Then they have pain when they have a bowel movement, so they're scared to have another bowel movement. And then we have this vicious cycle. All right, secondary constipation. Secondary is a pathological disorder. Could be from a partial bowel obstruction, and it will resolve when the primary problem is treated. So it's a secondary issue. You know, there's a primary issue that once we resolve the primary issue, the secondary constipation that goes with the issue will resolve. And then we have iatrogenic constipation. So iatrogenic is a consequence of another medical treatment, such as narcotics, which is a big one. So narcotics cause slow peristalsis, the stool stays in the colon longer, more water is absorbed, so you have harder, drier stool, and you have a lot of difficulty passing stool. So patients who are post-op, have had some type of surgery, are often getting narcotics for their pain, which leads them to be constipated. Then they have to, will use the Valsalva or have that increased abdominal pressure. But wherever the surgery is, especially if it's an abdominal surgery, I guess I should say, then we're just causing another vicious cycle, because then they don't want to have a bowel movement because it hurts. So oftentimes, if they put patients on narcotics, they will put them on a stool softener as well. And then we have pseudoconstipation. This happens when people are obsessed with having a bowel movement every day. People often will abuse laxatives and enemas. Now, elderly patients do this a lot, but younger patients do it too sometimes. It can cause more constipation problems because of the chronic purging, weakens the bowel tone, and they always have to have stimulation. They always have to have a stimulant to have a bowel movement. So they're truly not constipated. They're kind of making themselves constipated. All right, fecal impaction. This is what I talked about earlier. A large hardened mass of stool that interferes with defecation. Causes can be from unrelieved constipation, dehydration, weakness of the abdominal muscles. We can't push that stool through. Retained barium from an x-ray. Signs and symptoms would be the desire to defecate, but they can't. Rectal pain or liquid stools. So they can have this impaction and still have bowel movements. All right, so here's a picture of fecal impaction. Here's your normal anatomy. And here is your initial fecal impaction right here. Sigmoid colon is impacted with stool, and we have this stool still coming down the system, and this could still leak around the impaction. We could still have a bowel movement. Okay. All right, flatulence or flatus. Hopefully you guys know this is a medical term that you're going to need to know, but this is passing gas when you have gas, okay? So this is a really difficult thing to explain to patients who don't speak English. Don't know how you explain when I have a lot of Hispanic speaking patients, and I have a very difficult time asking them, C-section patients in particular, we're always asking, have you passed gas yet? I have a really hard time asking them, figuring out how to get them to understand if they've passed gas. But flatulence or flatus, the causes occur from swallowing air, slow peristalsis, gas that forms as a byproduct of bacterial fermentation in the bowel is normal. It's usually relieved rectally. Walking and rocking help. So patients can also get a lot of referred pain actually in their shoulders, especially after abdominal surgery, and it's gas. And, we have to really encourage them to get up and walk or rock to help that peristalsis alone get the gut moving again, and that will help alleviate that pain as well. If it is not relieved, we may need to insert a tube into the rectum to help release the gas. And here's my cute little fish don't get away with silent gas. At my house, nobody gets away with silent gas because there's no such thing. It's a game to see who can do it the loudest. All right, and any of you with boys know that probably. All right, diarrhea. Diarrhea is the urgent passage of a watery stool, usually with abdominal cramping. It begins suddenly and lasts for a short period. It is usually associated with nausea and vomiting and blood or mucus in the stool. Causes can be irritating substances, tainted food, or intestinal pathogens. Emotional stress can cause diarrhea. Laxative abuse and dietary problems. Some people will get, anytime they're really stressed out. Oh my gosh, why am I blanking on what that's called? Well, I'm sure there's a real medical term for it, but what do most people call it? Like a nervous stomach type thing. And so when they're real anxious or upset or worried or concerned about something, it just seems like everything just passes through the system much more quickly. So treatment for diarrhea is resting the bowel usually. They'll do clear liquids for 12 to 24 hours and then start on the bland diet, which they usually identify as the brat diet. So if you don't know the brat diet, it's bananas, rice, applesauce, and toast. If that's not relieved within 24 hours, they recommend that you call the physician. If you've done this for 24 hours, then you need to call the physician. Okay. Fecal incontinence. Fecal incontinence is the inability to control the elimination of stool. Stool is not always watery or loose when you have fecal incontinence. Causes can be neurologic changes. Neurologic changes that impair muscle activity, sensation, or thought processes. They may not realize they have to go. They don't feel that sensation that they have to go. They may not have the ability to control the muscles when they have to go. All right. It also includes if a person can't get to the toilet in time, i.e. with laxative, for example, with laxative use. Okay, so here's my picture. The guy has to run to the bathroom. All right, promoting bowel elimination. Oh, what do we got here? Suppositories, enemas. Oh, that's it. Suppositories and enemas. Several types of enemas here. Suppositories are oval or cone shaped. They melt at body temperature. They look like a little tiny bullet type thing, really. And you want to insert them using some kind of lubricant. I'm having a hard time coming up with words today. But you want to insert them using a lubricant, usually something like KY jelly or something of that nature. You put a little bit on the end of the suppository and insert it into the patient's rectum as far as you can, and then have them try to squeeze their butt cheeks together. You may have to do it for them so that the suppository is not expelled before it has time to melt. All right. Sometimes you have to do suppositories for patients who are having a hard time retaining oral medications. If we have severe nausea and vomiting, we may have to give medication via suppository. All right, enemas. We've got cleansing enemas and retention enemas. And then I'm going to discuss those in a little bit more in depth here. So cleansing enemas, we can do tap water, normal saline enema, a soap solution enema, or a hypertonic saline enema. And then we have retention enemas. I personally have thankfully not had to give an enema. Thank goodness. All right, enemas, cleansing enemas. Defecation usually occurs within 5 to 15 minutes. With the tap water, a normal saline enema is preferred for the non-irritating effects. Tap water is hypotonic, so the water is absorbed through the bowel. But careful monitoring if stool is still being expelled after the third enema, we need to call the physician, because what is going to be the concern? If we do 3 of these tap water normal saline enemas, we know that this is absorbed through the bowel. One of our big concerns is going to be fluid and electrolyte imbalance. All right, we do need to use caution with any type of large volume enema, because we still have, we think everything is safe. Well, everything has a risk. Everything has a risk. So the risk with enemas, if we do any kind of large volume enemas, that we may actually rupture the bowel. So we do have to be careful monitoring with all of that. Okay, then we've got soap solution enema is a mix of soap and water. Most disposable enemas contain a packet of soap with them. The ratio is 5 milliliters of soap to 1,000 milliliters of water or solution. The soap can cause chemical irritation to the mucous membrane, so monitoring is important. Make sure there's not too much and that the soap is not too harsh for the patient. Then we have hypertonic solution enemas. These are things like sodium phosphate. Is one of the solutions that would be used. It draws fluid from the body tissue into the bowel, increasing the fluid in the intestine beyond what is inserted in the enema. It is an irritant, however, on the mucous membranes of the bowel, so we have to be real careful about that. And here's my lovely picture of the enema. If you have to give a patient enema, just let me tell you, they don't really want it any more than you want to give it to them. So just try not to make a big deal about it and try to be, obviously, as with any procedure, you want to be as professional as possible. But they don't need to feel embarrassed or humiliated because you're having to do this for them. Just, go in and act like you do this every day. All right, retention enemas. This is when you have the solution, which would be held in the large intestines for 30 minutes. One example would be an oil retention enema. The oil lubricates and softens the stool for expulsion. The nurse instills 100 to 200 milliliters of warmed oil slowly. Now, why do we have to do this slowly? All right, one of the main reasons is because we need to decrease the, if we do it quickly, what we're doing is stimulating the urge to defecate. So we need to do this nice and slow so that we don't stimulate that urge to defecate, because then nothing's had time to work. Premature defecation defeats the purpose of this enema. All right, ostomies. Ostomy care. Ostomy is a surgically created opening to the bowel or other structure. We can have an ileostomy and a colostomy. Clients with ostomies wear an appliance over the stoma to collect stool and urine. A healthy colostomy stoma will be kind of a beefy red or a bright red in color. That's normal. Okay. Providing ostomy care, we need to prevent skin breakdown, is a major, major concern with these patients. Okay, we're going to wash the skin with mild soap and water, pat it dry, apply a barrier, something like Chiara. Not a lot, shouldn't say a lot, but there are places that are lucky enough to have an interostomal therapist. This is a nurse certified in caring for ostomies and related issues. Different appliances can be used, but all consist of a pouch and a faceplate. So, when do you empty the pouch? Maybe I should show you the pictures first. Where are the pictures? Right here. So, this is the faceplate that goes on the skin. And then here's your pouch that attaches to the faceplate on the skin. Okay, so when do we need to empty the pouch? Okay, we need to empty the pouch when it's between 1/3 and 1/2 full. You do not want it any fuller than halfway full. When do we need to remove the faceplate? Okay, we don't want to remove the faceplate any more frequently than every 3 to 5 days, because every time we do that, we're irritating the skin further. Every time we remove that faceplate, we're irritating the skin. Then we're putting a new faceplate on, going to irritate the skin again in 3 to 5 days. Okay? So, here is a picture of a colostomy that's done. So there's a cancerous tumor mass in the sigmoid colon and rectum are removed. A hole is made in the abdomen. The free end of the colon is pulled through the hole and stitched to the abdomen, creating a colostomy. So this is truly the colon pulled through the hole and stitched down. So if you'll notice, it has this nice, bright, beefy red color, and it should. Okay? These were the faceplates we looked at. And here's an example of a gentleman that has a colostomy. And look how bright red that is. Very normal. And he just has a little bit of stool in his bag there, so he didn't need to empty that. When he does, though, he'll just take the bag off and empty it. But he'll leave the faceplate on. Okay? There's probably a lot of people actually in the world going around with colostomies that we don't even know about, because they make these nice little pouches. They can tuck them into their clothing, and most of the time we never even know. All right, draining a continent ileostomy. A continent ostomy is an opening created for the drainage of liquid stool or urine by siphoning from an internal reservoir. So this is something totally, well, it's not totally different, but it's a little bit different. What they would do is they have this cock pouch. I don't know if I'm saying that right, but that's how I say it. But it's a pouch that is surgically made internally into the abdomen. Then what the patient does is they actually will catheterize the pouch to drain the stool or urine, wherever the pouch is, wherever this ostomy is created, so that they don't have to wear the bag, faceplate, and bag. So they have to kind of be on a nice regimen that they are self-cathing every 2 hours or whatever, so that pouch doesn't get full and overflow. But it is an internal, and there's a good description in your book, but it's an internal man-made reservoir for the stool and urine that then the patient goes in and will catheterize themselves through that pouch to drain it. No appliances needed, and they must drain at least every 4 to 6 hours. All right, irrigating a colostomy. Sometimes the installation of fluid is needed to promote the elimination of stool if it is more solid. Sometimes it's used to regulate the timing of the bowel movements. If a sigmoid colostomy, we may not need the appliance if we can regulate the emptying. So again, it depends on where the ostomy is in the system, in the GI system, as to what it's called, number one, and how we need to handle it. The client that if they have the sigmoid colostomy, they don't necessarily have to do not require an appliance if they can regulate the emptying and they expel no stool between irrigations. Okay? All right. The book has some great information on the skill sets 31.1 through 31.5 on 717 and 728, and I highly recommend that you review those. All right.